Hello friends, this is Dr. Pallavi Singh and I'm going to discuss about the topic Parkinsonism. So before going into the topic Parkinsonism, let's learn about the definition of Parkinsonism. So the Parkinsonism disease is a slowly progressive degenerative neurological disease that causes the effect in the basal ganglia and characterized by the tremor, rigidity, bradykinase, and also it causes posture instability. So there are two types of Parkinsonism, primary and secondary. The primary Parkinsonism is a disease which is incurable, and the secondary Parkinsonism is a disease which is curable. Next is the type of Parkinsonism. The type of Parkinsonism we have already studied. Then we are going to study about the etiology of Parkinsonism. In the etiology of Parkinsonism, the primary Parkinsonism is caused by the neuronal loss and also by the genetic factor. The secondary Parkinsonism is caused by the drugs and the chemical toxins, or we can say the poison caused by the chemical toxins and infectious diseases. The primary Parkinsonism disease, the normally high concentration in the basal ganglia of the brain is reduced in Parkinsonism. The loss of the dopaminergic neuron in the substantia nigra that normally inhibits the output of the GABAergic cells in the corpus luteum, which causes excitatory effect on the cholinergic neuron, and hence the symptoms are caused like tremors. There is a degeneration of the cells with loss of pigmented neurons in the par compensationa of the substantia nigra. The degenerative pigmented neuron contains eosinophilic inclusion bodies, and these eosinophilic inclusion bodies are called Lewis bodies, characterized by this disease or characterized of this disease. As we discussed in the etiology, the secondary Parkinsonism disease is caused by the drugs, and these drugs are includes dopamine antagonists. Some of the examples are phenothiazine and also the butyrophenones and also the reserpines, which are the poisons caused by the chemicals or toxins, and the carbon monoxide poisoning, heavy metal poisoning such as magnesiums and mercury. MPTP, a commercial compound used in the organic synthesis, are found in an illegal methylphenidine analogs, and the infectious causes, they are encephalitis virals. Coming to the pathophysiology, absorption of high potent neurotoxins such as carbon monoxide, magnesium solvents, and N-methyl-4-phenyl 1,2,3,6 tetrahydroxypyridine, which is a product of improper synthesis of the heroines like compound. Exposure to these agents along with the combination of neuronal loss of ages may be a cause of Parkinsonism disease. Now coming to the pathophysiology, the pathophysiology is discussed or divided by three parts. The first part is the Parkin, the second is the alpha-synuclein, the third is the CUCHL1. The Parkin is caused by the mutation, and this mutation causes accumulation of the toxin substrates, and this accumulation causes unfold protein stress, which causes cell death. Then coming to the alpha-synuclein, which is caused by mutation or by the environmental factors. These both causes the proteasome dysfunctions, and this dysfunction causes asynuclein aggregation as toxin intermediates, and this intermediate causes fibrins and Lewis bodies. Then UCHL1 causes mutation, and this mutation causes the impairation of the proteins, and this impaired proteins causes the accumulation of the toxin proteins, and this toxin proteins causes cell death. Next is the chemical features. The patient with Parkinsonism will have head bent forward, tremors of the head, drooling, rigidity, and stopped posture, weight loss, and also the tremor, and they will also have echinacea. Coming to the clinical evaluation, or we can say the clinical finding, by the imagining we can find the main origin of the secondary Parkinsonism disease. Next is the positron emission tomography, which is known as PET, and this is a scan which visualizes the dopamine uptake of the substantia nigra and basal ganglia. The PET scan measures the extent of the neuronal loss in these areas. Next is the single photon emission computed tomography, which is SPECT, which helps for the diagnosis of Parkinsonism syndromes and non-Parkinsonism syndrome. Particularly, it is essential in the tremors. Then the last one is the transcranial ultrasound, and this transcranial ultrasound examines the defects in the olifactions, and also the detection of the oligometry alpha synuclein in the blood of the patient with the Parkinsonism disease. Next is the scale of evaluating the disease progression. The first one is the Unified Parkinsonism Disease Rating Scale. It evaluates the clinical efficacy of the anti-Parkinsonism disease or the anti-Parkinsonism drugs, and to monitor the disease progression. And the next one, or the second one, is Humans and Yards scales, and this evaluate based on the posture instability. The last one is the Squab and England activity of daily living. It assesses the quality of life parameters of the Parkinsonism disease or Parkinsonism patient. Next, coming to the treatment. The treatment of Parkinsonism is done in the non-pharmacological and the pharmacological way. The non-pharmacological is by the patient have to take exercise, diet, speech therapy, physical rehabilitation, or the physiological rehabilitation. Next, coming to the pharmacological treatment, which can be done by the anti-Parkinsonism drugs, neuroprotective drugs, and the drug treatment or the drug therapy based on the symptoms of the patient, and lastly the surgery. The anti-Parkinsonism agent, the main dose or the initial dose is 50 mg, 8 or 2 hourly. Total dose is 1000 mg per day if necessary. Next, coming to the MOA, which is mechanism of action of the anti-Parkinsonism disease. It decreases the concentration of dopamine in the basal ganglia due to diminished number of dopamine releasing transcranial or the terminal in the striatum. Levodopa act as the precursor to produce more dopamine from the remaining neurons. Levodopa, the L isomers of the amino acid dihydroxyl phenylamine, which is the natural precursor of all the catecholamine neurotransmitters. Levodopa crosses the blood-brain barrier, which is taken up by the dopaminergic neurons for the substantia nigra and converted to the dopamine by the enzyme dopa decarboxylase. Levodopa therapy is a form of neurotransmitter replacement. The administration, it is available in combination with the peripheral acting dopa decarboxylase inhibitors in order to reduce the toxicity, or oral administration. Only 10% reaches the blood-brain barrier. The 90% is decarboxylated peripherally in the GIT and the blood vessels. Decarboxylase inhibitors thus not crosses the blood-brain barrier. The peripheral decarboxylase inhibitors are carbidopa and benserizide are available in combination with the levodopa. Neuroprotective treatment, dopamine agonist. It serves as the scavengers of free radicals and decreases the dopamine turnover, which reduces the oxidative stress. For example, the direct acting dopamine agonist can be bromocriptine or apomorphins. Next is the indirect acting dopamine agonist. It potentiates the dopaminergic functions by synthesis and releases of dopamine, blocking reuptake of agonists or antagonists of the glutamanergic cholinergic receptors. The decreased reuptakes are amantadine, and the decreased metabolism are selegiline. Non-ergot dopamine agonists are the scavengers of hydrogen peroxide and enhances the neurotropic activity, and also the examples are pramipexole and the leucerite. Thank you everyone, and thank you friends for listening me on Parkinsonism. Hope you understood the topic Parkinsonism disease. Meet you in the next video. Thank you.